Dear audience, let me present my PhD research about extraintestinal manifestations in inflammatory bowel disease. My name is Ágnes Tímár. I'm a PhD student and a pediatric resident at Heim Translational Pediatric Institute. My supervisor is Katali Müller and my SMS is Mark Hernátfői. I have a vision to improve the quality of life of IBD patients through proper treatment, and to achieve that, my mission is to assess long-term disease outcomes and treatment options of IBD patients with extraintestinal manifestations. I have two ongoing projects. In the first one, I'm comparing the effect of different advanced therapies on extraintestinal manifestations by conducting a meta-analysis. And my second project is a registry analysis about the relationship between extraintestinal manifestations and the intestinal disease course in children. So I would like to start with my first project and its importance. During the advent of anti-TNFs, they have been proven to be effective in IBD and revolutionized its management. However, 1/3 of the patients experience loss of response within 3 years, and in these cases, several new drugs are available. There is a group of patients within the IBD population, approximately 10–25% of them, who will develop extraintestinal manifestations. These patients face a greater challenge in their daily living due to greater symptom burden, higher peer burden, and impaired quality of life. It is a frequent misconception that the successful treatment of the intestinal inflammation will be always sufficient to treat extraintestinal manifestations as well. Therefore, it is highly important to adapt the treatment to cover extraintestinal manifestations too. And I would like to highlight our treatment options very briefly. We have ustekinumab, tofacitinib, and upadacitinib, which all have a systematic effect and are already applied in other immune-mediated conditions. And on the contrary, there is vedolizumab, which blocks the T cells from entering the GI tract, so it has only a gut-selective mechanism. Therefore, it is expected to have less effects on extraintestinal manifestations. And our aim was to determine which of these advanced therapies is associated with the lowest frequency of new extraintestinal manifestations. For that, we formulated our clinical question that what is the frequency of new extraintestinal manifestations during the use of different advanced therapies, and we investigated IBD patients who received advanced therapy, and our primary outcome was new extraintestinal manifestations, and the secondary outcomes improvement and worsening of already pre-existing ones. We hypothesized that the frequency of extraintestinal manifestations will be the highest in patients who received gut-selective biologicals. We conducted our systematic search on the 15th of November in 4 databases with this search key, which resulted in more than 13,000 hits. And during the selection process, we were able to reduce it to 61 eligible articles. So I would like to proceed with the results. As a general information, in all of my forest plots, a proportion was used as measure of effect, and subgroups were formed based on the applied drug type. So this first forest plot shows the proportion of new extraintestinal manifestations during advanced therapy when all of the extraintestinal manifestations are pulled together. And as I mentioned, we hypothesized that the frequency will be highest in patients treated with vedolizumab, and indeed, we found a higher proportion compared to ustekinumab-treated patients. However, it did not reach statistical significance. As extraintestinal manifestations are distinct diseases, we decided to analyze them separately as well. So this plot shows pooled proportions of new joint, skin, and ocular manifestations during advanced therapy. And here we can see that the new joint manifestations, so the proportion of new joint manifestations is higher in patients treated with vedolizumab compared to ustekinumab. However, the difference is not significant. And in case of skin and ocular manifestations, the proportions are exactly the same in the two treatment options. So we analyzed change in pre-existing manifestations as well. Here, this slide shows the improvement and worsening of pre-existing joint manifestation. And we can see that improvement rates were significantly lower in patients treated with vedolizumab compared to the ustekinumab subgroup. And the worsening rates were it was significantly more common in the vedolizumab subgroup compared to ustekinumab. However, moving forward to pre-existing skin manifestation, we did not see this difference, so the improvement was comparable between the vedolizumab and ustekinumab treated patients. Due to the lack of time, I can't show all of my forest plots, but we investigated several outcomes. And here I would like to highlight that we found a significant difference only in case of improving arthralgia, which is a type of joint manifestation. And all of the other results were comparable. So our study has some strengths and limitations as well. We were able to include a relatively high number of studies, and mostly all of them were published in the last 5 years. Additionally, we performed a detailed subgroup analysis and applied a rigorous methodology. However, there are several limitations as well. For example, no RCTs were available in this topic. The follow-up times were heterogeneous in the different articles, and the studies reported extraintestinal manifestations differently. So in conclusion, we can say that new extraintestinal manifestations seem to be rare during advanced therapy, and all of the results are comparable between vedolizumab and ustekinumab. However, the worsening of joint involvement was significantly more common, and improvement rates were significantly lower. Therefore, as a practical implication, we can say that there's no need to under-prioritize vedolizumab in cases of pre-existing extraintestinal manifestations, except where a joint involvement is already present. And as for the research side, we strongly suggest to come up with a more standardized reporting system regarding extraintestinal manifestations, and there is a need for prospective registries and detailed information about extraintestinal manifestations and these new therapies as well. So this slide shows my manuscript status. We are finished with the internal review, and we will submit our paper to the Journal of Crohn's and Colitis in a couple of days. So this is a D1 journal. And in the remaining time, I would like to talk about my second project, which is registry analysis, as I mentioned before. Extraintestinal manifestations are even more frequent in the pediatric IBD population. 25–40% of them will develop at least one extraintestinal manifestation during their life. However, little is known whether these patients experience more severe intestinal disease course. And we found a recent meta-analysis which showed that these patients have a higher risk of undergoing IBD-related surgery and receiving biological therapy. This meta-analysis included articles mostly with adults, so we are curious and interested whether the situation is the same in the pediatric IBD population. And there are already some suggestions in the literature that early aggressive therapy and the treatment escalation could prevent long-term complications in these cases. So our aim is to provide a descriptive analysis of the frequency of extraintestinal manifestations among Hungarian children based on the HUPIR registry, and to analyze the association between the presence of extraintestinal manifestations and the intestinal disease course. Now, our clinical question is that whether there's an association between extraintestinal manifestations and the intestinal disease course in pediatric IBD patients. So we will enroll children with IBD, and we will compare patients who already present an extraintestinal manifestations at diagnosis or develop the first one during the follow-up time with those who have no extraintestinal manifestations at all during follow-up. And our outcomes will be relapse rate, therapy failure, surgery, and steroid dependence. We hypothesize that patients who have extraintestinal manifestations have a higher risk of poor prognosis of IBD. And by answering this question, we plan to define the role of extraintestinal manifestation as a prognostic factor so that our patients could benefit from earlier treatment escalation. This is the summary of my two projects. I plan to submit the first one this month and the second one in September. I would like to finish my presentation with a quote that the best preparation for tomorrow is doing your best today, and thank you for your kind attention.
Congratulations for this brilliant presentation. My question is, what is the advantage of using vedolizumab?
Thank you for your great question. So, As I mentioned, that vedolizumab has only a gut-selective mechanism, where the others are systematic drugs. So it is considered to have a more beneficial side effect profile. For example, only with local infections, and it could be useful in more vulnerable patient population. For example, who underwent chemotherapy before this, or are elderly patients.
I'm just curious if you had analyzed the different type of arthritis, like axial and peripheral, because they behave differently, and maybe you can say if these treatments are better for one of them.
Yes, thank you. So originally we planned to analyze them separately, and we have some results for the axial manifestations. And as you mentioned, they have a different behavior of following the intestinal inflammation or not. But unfortunately for the peripheral type, we could not run an analysis because of lack of data, so we put them together.
I would like to ask, is there any explanation why the joints seems to be more vulnerable during the vedolizumab use? Why the arthalgia, etc., seems to be more common?
So mostly joint inflammation. So joint symptoms are independent from the intestinal activity in most of the cases, and also if, as I mentioned, the other two drugs, or mostly ustekinumab, is already applied in psoriatic arthritis, so they seem to have a better effect on joint symptoms.
Was advanced therapy mostly applied as second-line treatments?
Yes, thank you for your question. So mostly, yes, in some cases vedolizumab was used as a first-line treatment, but I would say that in 90% of the cases, all drugs were used as a second-line treatment.